Muted.
Alrighty, it's 2 p.m. Eastern Time on the dot. So hello and welcome everyone to today's session. On behalf of the Special and Vulnerable Populations Task Force, we'd like to welcome everyone to our second webinar of the 4-part National Learning Series focused on comorbidities associated with diabetes. Today's webinar will be focused on the diabetes continuum of care using behavioral health and substance use disorder integration to address older adults with cognitive impairments and diabetes. So my name is Albert Eisen, and I am the Senior Program Manager of Training and Technical Assistance at the Association of Asian Pacific Community Organizations, or also known as APSHO. I'm also joined by my esteemed colleagues, Joe Lee and Christine Alarcon, as well as Jillian Hopewell from the Migrant Clinicians Network. And we will be serving as your moderators for today's webinar. So about the series, this National Learning Series was created to address our diabetes epidemic, which is affecting more than 30 million people across the US. To combat and continue the national conversation around diabetes, the Special and Vulnerable Populations Task Force created this series to increase knowledge of effective strategies to prevent, treat, and manage diabetes among health center program patients. We are working with 14 national cooperative agreements, or NCAs, that are funded by HRSA and have partnered to create this meaningful content and to provide access to expert guest speakers for our audience today. Now, I just want to highlight the 2 NCA partners who are joined and helped us identify guest speakers today, and that is Dr. Jose Leon, Chief Medical Officer of the National Center for Health and Public Housing, and also Dr. Christine Reedy, Principal Investigator and Program Director at the National Center for Equitable Care for the Elderly. So I'm going to give them about a few minutes to talk about their NCAs. So Dr. Leon, go ahead.
Thank you, Albert, and good afternoon and good morning to you. You are on the West Coast. It's such a great honor to be part of this webinar. I'll just briefly talk about public housing and the National Center for Health and Public Housing. There are approximately 1.8 million residents living in public housing, and around 36% of them are children under the age of 17, and around 16 to 70% of them are senior residents. In 2017, health centers reported that they service around 3.5 million people living in on around public housing, and there are approximately 106 health centers receiving federal funds from HRSA to provide services to public housing residents and those living close to the public housing developments, and they service around 600,000 people in 2017. So the National Center for Health and Public Housing provides training and technical assistance to the health centers servicing public housing residents. And specifically, we have different activities and that we put together so we can improve the healthcare of those living in public housing. We provide some services such as webinars and community collaborations, mapping capabilities on different topics affecting public housing residents, like a smoke-free public housing or community collaborations on opioid, behavioral health, and trauma-informed care. So if you have any questions, our website is www.nchph.org, or you can contact me directly. My email address is jose.leon@namgt.com. Thank you for the opportunity.
Thank you, Dr. Leon. And next up, Dr. Reedy.
Thank you, Albert. Good day, everyone. Thank you for letting us talk a little bit about one of the newer national cooperative awards, the National Center for Equitable Care for Elders. As you may know, the older adult population has been steadily growing. It was approximately 14% of the population, U.S. population in 2014, and is estimated to be around 20% in the year 2050. What people are referring to or referring as a silver tsunami. We also have seen a decrease in the healthcare workforce that have been trained in providing geriatric care, as well as a lot of programs in different health professions have reduced the amount of curricular hours on geriatrics. And lastly, there's disproportionate poor health outcomes for older adults, particularly around chronic diseases. So our center was established to provide training and technical assistance for health centers on care for older adults. And you can see here some of the key topics that we address. Achieving health equity for older adults, improved access to health care, as well as behavioral and oral health integration, and improved knowledge of self-management of chronic conditions. We were established with the notion that that healthcare across the spectrum should be integrated, that certainly there are diseases that are not only chronic but comorbid to each other, and that in order to provide appropriate and accessible services to older adults, that health centers either need to provide supportive and enabling services or connecting with the various partners in their communities for providing community services to their older adults. Some of the things that we have been doing in the 2 years of our existence is, and I'll talk about this a little bit later, substance use disorders in older adults, geriatric syndrome and diabetes, looking at an environmental scan of social determinants of health related to care for older adults, food insecurity, and lastly, end of life, particularly palliative care. We can be reached at our website, ece.hsdm.harvard.edu, or you can reach me directly, christine.reedy@hsdm.harvard.edu. Thank you so much.
Thank you, Dr. Reedy. So we wouldn't be possible in this partnership without HRSA. So we acknowledge HRSA's support in our task force efforts in decreasing the percentage of health center program patients with a hemoglobin greater than A1C. And we are excited to develop additional resources such as the clinical change package for diabetes care, which will be published later this year from our partners at the National Association of Community Health Centers, MCN, and HRSA. So these are just some of the activities beyond the National Learning Series that the task force is engaged in. And our National Learning Series will be utilizing the Diabetes Continuum of Care framework. And today's webinar will be focused in particular on improving health systems and infrastructure, which is one of the 3 main strategies for diabetes prevention and management. And today's agenda will include, of course, this 90-minute presentation, including a Q&A. So please type in your questions on the right-hand panel. And the learning objectives are here in front of you as stated: to understand the prevalence of substance abuse among patients with diabetes and to describe a collaborative model for treatment in a health center setting. Second, to explore a clinical perspective on behavioral health and substance use disorder integration for patients with diabetes, in particular medication adherence. Third and last, to identify resources to address substance use disorder among older adults with cognitive impairments. So without further ado, I'm happy to introduce our speakers for today. The first one is Dr. Elizabeth Davis, who is a board certified internist and psychiatrist. Dr. Davis is there's some feedback, so if you are mute yourself.
Is that on?
Apologies, everyone, just a minute. Sorry for the feedback. People are still joining, so okay, so back to where I was. Dr. Davis is Chief of Adult Medicine and the Medical Director of Addiction Treatment Program at the South End Community Health Center in Boston, which is one of the oldest health centers in the United States. SCHC is also located at the epicenter of the opioid crisis in Boston. Second, we'll have and be joined by Dr. Saria El-Haddad. Dr. El-Haddad is board certified in general psychiatry and addiction psychiatry. She currently practices at Brigham and Women's Faulkner Hospital's Department of Psychiatry, where she provides psychiatric leadership for the dual diagnosis partial hospital program and serves as an attending psychiatrist for the outpatient addiction recovery program. Lastly, and we'll be joined by our esteemed NCA partner, Dr. Christine Reedy, who works as the principal investigator and program director at the National Center for Equitable Care for the Elderly. Dr. Reedy is the Delta Dental of Massachusetts Associate Professor in Oral Public Health and Epidemiology at the Harvard School of Dental Medicine and Chair of the Department of Oral Health Policy and Epidemiology. We are definitely honored to have our speakers with us today, and their full bios will be made available on diabetes.apsho.org along with the slides and recording post this webinar. So be sure to check back in a couple of days. All right, so quickly, some housekeeping for you all if this is not the first time you're doing GoToWebinar, but we do have some screenshots here in front of you on the GoToWebinar attendee interface, which is made up of two parts: the viewer window on the left and the control panel on the right. The viewer window allows you to see everything the presenter will share on their screen, and the control panel allows you to participate in the webinar. As for questions and comments, please note that all attendees are in listen-only mode for the rest of the session and will be muted for the webinar duration. You may submit questions during the presentation by typing them in the questions field of your control panel, and we'll be reviewing questions as they come in, and we'll address them during the Q&A portion held after the formal presentations. Today's webinar is being recorded, so please sit back and relax, and all attendees will receive an email with the link to view the recording post-presentation. You can also interact with us on Twitter using @AppShow tweets and use the hashtag Diabetes National Learning Series. Alrighty. And my last announcement is around CME and CME accreditation available. We'd want to make sure that during the post-webinar survey that you fill out the fields asking about the information and requested details on if you want to receive an electronic or hard copy of your certificate. This is made in due part thanks to MCN, the Migrant Clinicians Network. So if you have any questions about accreditation, you can contact Martha Alvarado at malalvarado@migrantclinicians.org. Alrighty, without further ado, I'd like to introduce Dr. Davis to kick off our presentations.
Okay, thank you very much.
So I'm Elizabeth Davis, and I'm the director of a substance abuse program in Boston that is integrated into the primary care department, where we administer both medical and psychiatric care to our patients with substance use disorder. We have at our clinic approximately 16,000 patients that span from children to adults, and we have about 26,000 visits a year, just to give some context. Now, I'm sorry, I can't see the arrows here.
Let me double check that for you.
Usually I have the arrows at the bottom left-hand corner and I can't see them.
There you go.
There. Okay, great. Thank you. Okay, so the objectives of my talk are to provide a context and with some background statistics to understand the scope of substance abuse in the United States and in our healthcare system. I'm also going to describe a collaborative model for substance abuse treatment in a federally qualified community health center. And I'm going to discuss the impact of chronic disease and mental status on the management of substance use disorders. Okay. So just to give some background, and I'm realizing that the statistics I'm presenting here, which I believe I got from the CDC, actually from SAMHSA, might be somewhat different than the ones proposed in the beginning. But of adults in the United States who are older than 20 years old, there are approximately 25 million patients who are diagnosed with diabetes. Perhaps the 33% that was cited in the beginning includes children, I'm not sure, but this is probably an underestimation. And the 25 million constitutes 11% of the population. If you broke it down to those adults who are over 65 years old, almost 11 million adults over 65, or 27% of the population, are diagnosed with diabetes. So almost a third of the entire population of the United States who are over 65. And among non-Hispanic whites who are older than 20, if you compare this to non-Hispanic blacks, the percentages of those populations are higher among black patients than white patients. We also know that the medical expenditure costs for patients with diabetes are more than 2.5 times those for patients without diabetes. And those with both diabetes and mental illness accounts for the most ER visits and hospital readmission rates in the United States. Again, I don't have the arrows, I'm sorry.
Let's get that fixed for you.
Or you can just change the slide, it's fine.
Yep. Now I'm not. Okay, there you go.
Okay, great. All right. Okay, so just some background statistics from SAMHSA and the CDC regarding substance use disorders and mental illness in the United States. We know that 18% of adults over the age of 18 have mental illness. Approximately 20% of patients with mental illness have substance use disorders. 9% of adults over the age of 18 are diagnosed with substance use disorders, and 3.4% of adults over 18 have been diagnosed with both mental illness and substance use disorder. And because we know that only 10%, or 1 in 10 of patients who present with substance use disorders actually get treatment, this is probably a gross underestimation, is my guess. So what is the prevalence of substance use disorders among patients with diabetes? This is a study that was done at Duke University in North Carolina. It's a good example of the kinds of the ways we think about our own patients in our health center. in terms of addressing the highest risk patients, those we know are utilizing the emergency rooms and hospital readmissions more than anyone else. And so what they did at Duke is they looked at patients with diabetes who satisfied the highest top 10% risk score for poor outcomes. And they looked at these patients over a 2-year period. What they saw was, when they're talking about substance use disorders, actually they included tobacco as well in this population, which I thought was interesting because usually we separate it out. And when we talk about mental health disorders, we're thinking about depression, bipolar illness, which are both mood disorders, anxiety disorders, and those with psychosis or disorganized thinking, and cognitive disorders and sleep. And cognitive disorders are included in that, and that would be dementia, for example, which we would see in an older population. And what they saw was that 82% of this top 10% tier patients, this is the sickest of the sick, and they had 263 patients who were monitored over a 2-year period, that almost 82% suffered from both substance use disorders or a mental health disorder, and that 41% suffered from both a substance use disorder and a mental health disorder. 33% only had mental health disorders but no substance abuse, and 6.8% suffered from substance use disorders without a mental health disorder diagnosis. Only 20% of this high risk group of patients did not suffer from substance abuse or mental illness. They also noticed that there was a strong association between diabetes and COPD in this population. COPD is lung disease caused by smoking usually. It can be environmental exposures as well. And so I think this is why the tobacco was included in the substance use disorders. And as we know, it is common knowledge that both substance use disorders and mental health disorders account for the highest levels of emergency room visits and hospitalizations. So we also know that there is a relationship between diabetes and substance abuse and also mental illness. These are all well-established associations. We know that insulin resistance, the precursor to diabetes, is linked to mental illness independent of medications. So we know our medications cause metabolic problems, including diabetes. We also know that people who suffer from mental illness are less likely to attend to their medical problems. However, separate from that, there is some correlation between insulin resistance and people who have mental illness. We also know that there is severe psychological distress among those who are diagnosed with diabetes, and it's 2 times as high as it is among those without diabetes. We also know that people with depression have a 60% chance of developing diabetes. So they're extremely interrelated. We now know also that most illicit substances and legal substances have some impact on insulin resistance and metabolism. So drugs such as ecstasy, ketamine, cocaine can trigger acute diabetic symptoms, including hyperglycemia. Heroin, we know, is associated with insulin resistance, and patients with hepatitis C infection, which is often contracted by IV drug users, may also induce insulin resistance. People who suffer from alcohol abuse, those who binge drink but don't eat, often can present to the hospital in hypoglycemia. Those who do drink but are not starving have a higher rate of hyperglycemia and can ultimately result in severe life-threatening conditions related to diabetes, including ketoacidosis. Also, we know that alcohol abuse can lead to pancreatitis, which also worsens hyperglycemia due to insulin resistance. Interestingly, marijuana has been associated with a lower prevalence of diabetes. It's also understood that the impact on cognition is multifactorial. Age, substance use, mental illness, and diabetes are all independently impact cognition in a negative way. There's an augmentation of this impact when all three are involved. And cognitive compromise has a negative impact on behavior, capacity to learn, and judgment. There are risks for infection and cardiovascular disease, which further impact cognition and ultimately can result in acute confusional states or delirium. It may increase the risk for medication and substance misuse, and management, therefore, must be multidisciplinary and supportive to include case management and outreach, community outreach as a prominent feature. So it has been studied over the last 20 years, different models for taking care of complex patients. And I'm going to discuss some of those models. But first, I'm going to give you some background on the impact, which we are all hearing about with the opioid crisis. So 65,000 overdose deaths occurred in 2016 alone, which is twice as many since 1999. Only 1 in 10 actually received treatment for substance use disorder, which makes me think that the numbers initially, where we talked about prevalence of substance use and chronic disease, are an understatement. In Massachusetts, we experienced one of the largest growths in overdose deaths. The rate more than doubled from 2013 to 2016, and we believe this is due to fentanyl, which constitutes the majority of our heroin sales, and also cocaine, and it's also in marijuana. It's in pills that are sold on the street. It's in everything. However, fortunately in Massachusetts, we saw a 4% decrease in deaths in 2017. And we attribute this improvement to the improvement in resources, medication-assisted treatments such as Suboxone, Methadone, and Vivitrol or Naltrexone, Narcan education, and Medicaid expansion as well in our state that we are fortunate to have. This slide just gives you a sense of how important using medication-assisted treatment is in improving survival outcomes. So patients who are in treatment are in blue, and those out of treatment for 1 month are in orange, and then out of treatment for longer are in gray. What you can see is that within the first 4 weeks of leaving treatment, so giving up your buprenorphine or methadone, have a 90% chance of relapse within 1 month after stopping buprenorphine. The rate of death from overdose in the first month approaches 50%, so it's an incredibly dangerous and vulnerable time. Whoops, I think I might have skipped one. All right. Oh, sorry, I think I'm going back. Can we go back to the slide?
Sure. Let me help you there, Dr. Davis.
Now I can't
okay,
see.
there you
go. Okay.
There you go. You can keep going back to, I think you're on models for caring for complex patients.
I want to talk about the models.
Yep. One more. Good. Great.
Okay. Let me just make sure. Okay. So I'm going to present sort of some background on what kind of models we think about when we're taking care of complex patients. there's a collaborative care model, and these are basically all some form of collaborative care. But this is a model in which treatment is given to high-risk populations in a co-located health center. So you can either have, for example, a primary care clinic in a behavioral health facility, or you could have behavioral health treatment that's integrated within a primary care setting or a medical setting. And this is traditionally, it started off actually in HIV treatment and has expanded to mental illness, treatment of mental illness, and also substance use. There's also an integrative model of primary care, which includes a multidisciplinary team within what we call a medical home, and it can include nurses, a behavioral health clinician, case management. It focuses on education of patients and staff, and also community outreach. And then there's the nursing care manager model, which was founded in Massachusetts and Boston, and it was developed to take care of patients with substance use treatment. And it interfaces with primary care, but it has a specific supportive role in that it takes care of people with substance abuse, and it focuses on the substance abuse. It also allows patients to have something called low barrier treatment. This means that patients are provided medication-assisted treatment immediately upon engagement, and also regardless of whether or not they're actively using or not. And it also affords sort of easy access into treatment, and also at different stages of recovery. So our program at South End, we call our program Support Wellness. It employs really all three models. The nurses play a central role in managing the majority of the substance use care. The medical home that we're in provides a fully integrated care model with primary care providers who provide the general medical care and primary prevention of chronic diseases. We have case management, and we also have pharmacological specialization as well. We take care of specialty, we give specialty care to patients who suffer from Hep C, hepatitis C, and HIV, and also behavioral health problems. There is a fluidity of roles amongst our team members, and our team is comprised of 10 members. And all team members participate in co-leading groups. We have groups daily, often multiple groups in one day. We have uniform training and shared philosophies of care, and we collaborate in our decision making, and we meet for 3 hours a week to go over our patients, to discuss their care. We're situated in South End Community Health Center, and I just wanted to give background that we have many, many different departments, from pediatrics to adult care, specialty care in eye and dental, women's health, and we have an integrated behavioral health department within our primary care and pediatric settings. Regarding the demographics of our program, this is based on data from 2016 to 2018. At that point, we had 189 patients enrolled. We now have about 240 patients enrolled, so this might look a little bit different. But what we see is we have about 30% of our patients are of Hispanic origin, and 65% are declared as non-Hispanic, and 6% unknown. Throughout the health center, we actually have about 40% of our population is Spanish-speaking and Hispanic, and 60% is non-Hispanic. We take care of patients who have all sorts of addiction. But the breakdown in June of 2018 showed that the majority of our patients suffered from opioid disorders, and then cocaine and alcohol abuse were roughly more equal, but that there was a lot of overlap. And then the age range that we take care of is from really just 20 years old to 70 years old. We have a couple of patients who are over 70, but that the majority are between 30 and 40 years old, and that the majority of our female patients are of childbearing age. Also, this shows at that time the distribution of diagnoses of mental illness, and that the vast majority suffer from anxiety, and a large proportion of those have PTSD and generalized anxiety. Over the past 3 years that we have been active, we've been particularly interested in retention and engagement. And our primary goals are survival and retention of our patients, given the immediacy of the crisis. Certain interventions, we believe, are closely linked to retention, and those are the concept of harm reduction, which is our main goal, is to reduce harm and death. And therefore, how we approach treatment is through this low barrier induction, where you don't wait more than a day or two to start medication-assisted treatment. We're also non-judgmental, and we have open access. So we maintain patients even when they break certain rules or are struggling to maintain complete sobriety. We also have integration of both medical and behavioral health, where we have individual therapists, group therapy, primary care, and nursing care. We also have case management. We also know that MAT, or medication-assisted treatment alone, is insufficient for successful linkage to community resources and long-term recovery and overdose prevention. We have distinct strengths in our group, and that is that we have 2 nurses with dual diagnosis experience. They both practiced in behavioral health settings, psychiatric hospitals, prior to joining us. I myself am dually trained as an internist and psychiatrist, and while I do have a primary care practice, I also do the psychiatric medication evaluations for many of our patients. And we now have a psychiatric nurse practitioner who also recently joined. We have a case manager with a background in HIV/AIDS resource linkage, sexually transmitted disease screening, and LGBTQ youth advocacy. And currently, we have funding now to develop a peer recovery coach program, and are hiring an individual who themselves has suffered from substance use disorder but in recovery, who will provide support and assistance to our patients. And this is just another slide showing our retention rates, and that basically patients who are on medication-assisted treatment had much greater retention at 18 months, at 6 months, 12 months, and 18 months than did patients who were on no MAT. And the green is for naltrexone Vivitrol, which we use for both opiate dependence and alcohol dependence as well. This has been extremely rewarding, and we think it's rewarding because we're able as a team to make successful and impactful connections with our patients. We enjoy thinking outside the box when caring for complex patients. We are not very conventional in our approach. We're collaborative. We support one another. We have the philosophy, we never worry alone. We make a number of connections with a team that we know it correlates with overall retention. And we have a positive impact on our patient, all their health needs, both medical and psychological. And I think we have to remember that taking care of patients who have issues such as diabetes and substance use, we have to think about stigma and how it impacts our medical treatment, and that we know that it's more common to receive substandard care. We know that funding for addiction programs can be, that don't also provide multiple medical and behavioral health services, can end up being a disservice to the overall care of complex patients who really need a holistic care, and that we know the outcomes are better. and that we know that regarding aging and substance use, that this population is actually on the rise, and then upwards of, I believe it's upwards of 12% of patients who are over the age of 65 have a recent history of abusing illicit substances. We also know that our patients, because of their complex medical and psychiatric issues, are at risk for cognitive decline and delirium, and are at risk for medical problems that also increase this risk of cognitive decline and delirium, including infections being one of them, and cardiovascular disease as well. Also cirrhosis in the case of people who have hepatitis C and alcohol dependence. So this is just the names of people on our team and those who have been instrumental in providing us with data. And we're funded currently by HRSA and SAMHSA, and we've held grants from General Electric as well. Thank you.
Thank you so much, Dr. Davis, for this timely and relevant conversation. As you mentioned, HRSA, they recently announced, a bunch of funding to support behavioral health and primary care integration and really tackling the opioid epidemic in the local communities. So you're doing a model job in Boston, and we hope to hear more from you in the future.
Thank you.
Great. So with our next speaker, and please chime in with questions in the question box. That way we can monitor that for the Q&A session. I'd like to present now Dr. Saria Haddad from the Brigham Health, and she'll talk about more of the clinical perspective and medication adherence. So Dr. Haddad. And I can advance your slides for you if you don't have the arrows. Here we go.
Okay. Hi, can everyone hear me okay?
Yes, you sound good. Thank you.
Okay, thanks. So thank you for inviting me to give this talk. In the next 15 minutes, I'm going to be covering challenges in adherence to medications in a particularly complex patient population, the elderly population who have substance use disorder and cognitive impairment. I'm not able to, okay. So during the past few years, the concept of adherence has gained popularity over the concept of compliance, because the term compliance implies more responsibility on the patient's end, whereas adherence implies more of a collaborative union between the provider and the patient, and implicates that responsibility falls on the provider, on the patient, also on the system itself in terms of improving adherence. And nowadays, the WHO defines adherence as the extent to which a person's behavior, taking medication, following a diet, and or executing lifestyle changes corresponds with the agreed recommendations from a provider. The first studies on adherence started around the late 1960s, and sorry, trying to move through. Thanks. So despite several decades trying to study adherence and finding tools and clinical applications to improve adherence, there hasn't been any really solid algorithm that has been developed and showed to have significant impact on our clinical practice in terms of improving adherence, which tells us that this is quite of a challenging problem that we have. But by definition, non-adherence is taking less than 80% of prescribed doses, can also include misuse of medications, so taking too many doses, combining doses, taking them at a time where it's not recommended. And it's obviously associated with increased risk of poor outcomes, mortality, and adverse clinical events. Low adherence even to placebo is independently associated with an increased risk of death, a phenomenon called the healthy adherer effect. And in part, this is due to the fact that low adherence is more of a symptom of an overall condition or lifestyle that the patient is leading that is not healthy in general. Next, please. Okay. So there are many determinants of adherence. So non-adherence is not only related to individuals' behavioral factors, but also to many factors. And the WHO divided determinants of non-adherence into 5 dimensions: social and economical, health system related, therapy related, condition related, and patient related. And under patient related, you can see that cognitive impairment is one of the factors that can affect adherence. Next, please. More things happen as we age, and there are natural stressors that accompany the process of aging that some of them are actually unavoidable. So with aging comes role and status change, especially retirement, income changes, physical health decline, which is when patients have multiple medical conditions, it can lead to polypharmacy, meaning taking multiple medications at the same time, cognitive changes, widowhood, shrinking social network. But perhaps by far the one factor that affects people's quality of life is loss of independence. And those factors not only can affect adherence to treatment and medication, but they are also independent factors that can increase the risk in the geriatric population of developing substance use disorder, in particular in that age range, alcohol use disorder. Next, please. So, and until recently, the elderly people have been excluded from some of the randomized controlled trials studying medication, perhaps because maybe principal investigators thought it would be a high risk involving a population with multiple comorbidities. And recently, the European Research Consortium has advocated for active involvement of the elderly people in clinical trials, because as you know, randomized clinical trials are the gold standard by which a medication is placed on the market, and there are guidelines are developed to use this medication. And if those medication, in terms of benefit and risk, are studied mainly in the young, healthy population, we can't really extrapolate this benefit and risk to the geriatric population, which can have maybe equal benefit, but probably more risk. So it's important to involve this population in those studies. What the studies tell us is that the elderly population have way higher risk of developing adverse side effects to medications than younger people. In Europe, 20% of older people receive at least one inappropriate drug. By definition, inappropriate drugs, according to the American Geriatric Association, under the BEERS criteria, are medications that are more likely to cause harm than benefit in elderly people. Medications, for example, like benzodiazepines, anticholinergic medications, with potential risk of causing, for example, falls, fractures, or changes in cognition. But unfortunately, the reality is that a lot of people do receive those medications. 30% of hospital admissions among elderly people are caused by adverse effects of drugs. And more than 50% of adverse reactions observed in the elderly people are actually preventable. There are barriers that are unique to patients with substance use disorder, regardless of their age. In this patient population, around 50% of patients will have a co-occurring psychiatric disorder. The majority of those would be mood disorders or anxiety disorders. Sorry. The studies are solid in proving that the presence of those co-occurring disorders can actually further complicate adherence to treatment and to medications. Another barrier is that during active drug use, patients are likely to forget taking their medication, they take it at a wrong time, or sometimes if they realize that they miss a dose, they take 2 doses at the same time. One statement that I've heard very frequently from patients is that I don't want to mix my meds with alcohol, so when they're having an episode of binge drinking, they'll stop taking their meds. Not only their psychiatric meds, I have a patient, for example, with type 1 diabetes who stops taking her insulin, and has repetitively been admitted to the emergency room with diabetic ketoacidosis due to drinking and not taking her medications. Barriers that are unique to patients with cognitive impairments. Obviously, there are self-explanatory, so those patients have more challenge in understanding new directions, especially if we're switching meds, explaining that they need to taper the medication off, start the medication slow and titrate up. Those directions can be quite complicated. Living alone obviously becomes a problem when we're trying to educate a patient about medication intake and they have cognitive impairment, scheduling their medication into the daily routine. And sometimes patients with cognitive impairment will have a hard time accepting or understanding why certain medications are important, and they might just refuse taking them. So what are tools that would help improve adherence? Studies have looked at multiple things. Obviously, the studies cover patient population of various ages. The first few bullets are from studies that have covered the adult population in general, not so much the geriatric population. I'm going to talk about each one separately. Behavioral interventions is basically when we incorporate some cognitive behavioral therapy techniques or some motivational interviewing techniques into the patient education. That can be done separately by a therapist, or it can be done by the prescriber himself or herself, using those techniques to improve adherence to treatment and to medications as well. Behavioral interventions have been shown to be helpful. There was a paper that showed that a single consultation-based session of 30 minutes performed by a trained nurse enhanced patients' adherence to medication, to diabetes medication, and effectively lowered the serum glucose levels in older patients. Behavioral interventions, obviously, they're not easy to implement, and we all know how the pace of medicine is nowadays, and trying to carve out this extra 30 minutes to do this might not be very practical, but it was shown to be effective. Educational interventions is more of a psychoeducation of the patient about the disease, or just education about the disease, the treatment, and more of a patient-centered care, patient-centered framework and shared decision-making. So that intervention alone was not shown to have a significant statistical impact on improving adherence. The outcomes of those studies have shown that patients have verbalized better understanding of their illness and its treatments, but it hasn't really affected how much they're adhering to their medications. However, the studies that have combined both behavioral interventions and educational intervention showed a statistical significant improvement in adherence. Third is integrated care interventions. Dr. Davis spoke a little bit about that earlier. So integrated care is when there's a lot of collaboration within and between healthcare providers at different levels, whether it's at the administrative level, provider level, multiple providers at the same time, obviously. And it aims to increase the quality of care and the healthcare satisfaction overall. So it has a lot of benefits, and this is the ideal way of caring for this complex patient population, obviously. On a practical level, it can be daunting sometimes if those different healthcare providers are present in different areas, if they don't have the same electronic medical record, if the communication is not as fluid. It can be a bit complicated, but it is a very ideal way of caring for this complex patient population. And they seem to have a positive impact on patient care quality. Self-management intervention is a little bit similar to the theory behind educational intervention in terms of helping the patient take the initiative to promote their own health. So, and that would be using various tools, like, for example, accessing their medical records and sending messages to their providers, initiating an exercise regimen, self-monitoring. An example, for example, an example that I use is I have patients log for how much they drink, and they bring their log at every visit, and we look at the numbers. I also have them log sometimes their blood pressure, and we also look at that with regards to like withdrawal periods or side effects of medications. So basically what this strategy aims at, improving the patient's lifestyle choices, helping them in self-monitoring, accessing their own records, and adhere to medications. And the use of technological devices in self-management can also be helpful. There are some apps that we use sometimes specifically for addiction that have been shown to be helpful. Risk communication also falls under the from the same concept of educational intervention, but it's more focused on risks. So in that intervention, we focus mostly on, okay, what's the risk of you not getting treatment? What's the risk of you getting this medication? And what is the benefit of this medication? And we make a risk-benefit assessment and an informed decision. And several like decision aids have been developed for patients, for example, pamphlets, videos, web-based tool, and they have been shown to help in improving adherence. Perhaps most of the studies that were done on improving adherence are about packaging and daily reminders. And this is by far a strategy that was found to be very helpful in all patient populations. So there are different kinds of reminders that are used. For example, reminder phone calls, text messages, pagers, interactive voice response systems, video telephone calls, medication boxes, personalized blisters, and all studies across the board have showed that reminder in any variation and reminder packaging have a positive impact on medication adherence and on the clinical results as well. So just to mention that those interventions have been done on the general population, so not on the complex population that we're focused on today, which is the elderly population with a cognitive impairment. The studies that looked at patients with cognitive impairments are not, there's not so that many of them, but the ones I found, they indicated that, for example, in terms of the daily reminder intervention, using human communication tools is much more effective than non-human reminders such as text messages or emails, for example. And among all the those strategies that I mentioned in this complex patient population, by far the most effective and helpful one is the integrated intervention. They also mentioned examples of regular medication reviews, what we also call the brown bag review. So at every visit, we have the patient bring their medications. We review it with them and with their care, like if they have a caretaker. We write things down at every visit. Physician-pharmacist cooperation is also helpful because oftentimes when a medication is discontinued, it might not go straight to the pharmacy as a discontinued medication. They might fill it and the patient might not remember that this was discontinued. So obviously also communicating this to the pharmacist on a regular basis, updating the list is very helpful. What I also noticed in the readings on this patient population with cognitive impairment is that adherence follows a U-shaped curve. So initially, when the patient starts experiencing the cognitive decline, obviously this patient has been used to taking their medications alone and coming to their appointments independently. But when the cognitive impairment starts initially and it's mild to moderate, this is when adherence is really like dropping significantly. However, as the cognitive impairment advances and various healthcare providers pick up on it and a caretaker becomes involved in their care, this is when you see adherence going up again. So it's like a U-shaped curve, adherence to appointment, adherence to medications. One thing from a practical level that we also noticed here is that it's important also to ask about the caretaker's condition, because most of the time the caretaker, the caregiver is a spouse, and if the spouse is also elderly, they might have their own challenges. We want to make sure that they're not burned out and that they are also capable of grasping this information and handling all the medical appointments and the medication changes. So it's often helpful to ask the caretaker like how they are doing and if they need further assistance. I guess that's all I have for today. Thank you for your attention.
Thank you so much, Dr. El Haddad. That was very insightful, and just the walkthrough of your different interventions and strategies. I hope everyone has been taking great notes, because this is really important to really care for the complex patients and our elderly patients. It takes a village, as we like to say.
Yeah.
So, Dr. El Haddad, I'm not sure if you're going to stay on for Q&A, or do you have to step out for patient?
I can stay for like 5 minutes.
Oh, okay.
I have a meeting at 3, but I can be a little late, so it's okay.
No worries. In this case, yeah, if people have questions for Dr. El Haddad, please specify in the Q&A box. That way we can direct them offline. So I hope that works, Dr. El Haddad.
Yes, thank you.
Awesome. So thank you so much. All right, so let's move on to our last presentation by our NCA faculty, Dr. Reedy, and we'll follow up with Q&A after that.
Thanks. Shall I answer the questions in the text box, or?
You could, yes, Dr. Haddad, if you want to chat it in
Okay.
to that.
Okay. Yes.
Yep. Good use of your time. Thank you.
I'm going to type it. Thanks.
Perfect. And now next up, Dr. Reedy.
Thank you so much, Albert. And I hope everyone can hear me okay. And
yep, you're good.
I will just make it easy on myself as well as others. And Joe or Christine, I will ask you to go ahead and advance my slides. So
I got you, Dr. Reedy.
Okay, thank you so much. So for the last presentation today, we just wanted to provide a little bit of information in relation to a learning collaborative that we had conducted in the fall of 2018. And it was specifically on substance use disorders and addictions among older adults in health centers. This screen shows an overview of the Learning Collaborative sessions. We really did a very broad overview of substance disorders with respect to the types and rates of substance use disorder and addictions among older adults and older adult health center patients, as well as describing the unique vulnerabilities for older adults with substance use. For example, the role of polypharmacy in unintended opioid misuse. We also explored substance use diagnosis and reviewed the opioid epidemic in context of older adults, and recognizing the challenges to identifying substance use disorder in older adults, and to appreciate the role older adults can play in overdose prevention, as well as something that Dr. Davis had mentioned earlier, the stigma of identifying and treating substance use disorder in older adults. We were very glad to have Dr. El Haddad, who talked about screening and assessment, some of the screening instruments focused on the older adult population, because as I'm sure you are well aware, oftentimes screening instruments may not be entirely appropriate for the population of study. This sometimes happens with assessments for children, as well as the other end of the age spectrum with adults. We also talked about different treatment and referral strategies, and in terms of team-based care, and then also around case management. And then in our last session, we talked about an innovative program that was developed in Florida, known as the Bright program. And so I'm just going to talk a little bit about some of the highlights from those sessions for the remainder of the presentation. So I guess really to say, why is this important? And I think overall, the way that we framed our collaborative session was around this statistic, that there is a projected increase in substance use disorder rates for adults 50 years and older. Going from the statistic in 2006 that there were 2.8 million to 5.7 million in 2020, which hard to believe is next year. So again, it's something that we need to focus on. The other thing that I want to mention is the age frame that we have here, adults 50 years and older. And certainly when individuals have been using substances for a number of years, the changes that take place physiologically often relate them more to an older population. We also see that, as I'm sure Dr. Leon can attest to, within unstably housed individuals as well. So a lot of time we talk about older adults as 65 and older, but depending on the life circumstances, we may be seeing the older adult issues in a somewhat younger population. Next slide, please. So we wanted to highlight some of the issues that impact older adults, and that is around prescription drug abuse. And you can see here, based on the different classes of prescription drugs, that some of the things that can impact their health may also mirror issues that might be related to general aging. So falls, delirium, cognitive impairment, loss of balance. And so it can be important to tease out, is it an aging issue or an issue related to aging, or is it an issue related to substance use? Next slide, please. And again, expanding on the use of prescription or misuse of prescription medications, and particularly the risk of harm from polypharmacy in older adults. I think that certainly there are a number of older adults as well as a number of adults in health centers where they really are on multiple prescriptions, greater than or equal to 5 prescriptions is referred to polypharmacy, and they can have a myriad of health issues. And certainly with polypharmacy comes the potential issue of memory impairment, and it can result in memory impairment, and then also cognitive dysfunction related to aging may also cause memory impairment and may make it difficult for them to take medication accordingly, or to adhere with medication regimens. And so when we bring in the diabetes aspect as well, we know that there's a bidirectional relationship with cognitive dysfunction and diabetes mellitus, and that the number is approximately double for people with diabetes who are over the age of 70, those who have cognitive dysfunction. We also know that cognitive dysfunction is associated with poor diabetic control. So now we have the interplay of these different issues. And what we see is that there are, when we talk about cognitive impairment, there could be different behaviors that are impacted. So we may have a memory issue, we may have an attention or orientation issue, we may have a language issue or a visuospatial issue, or we may have executive function. And executive function is around the planning and judgment. When we talk about executive function, we oftentimes talk about teenagers and late teens in terms of their executive function is not fully formed. But we also see this in older adults with cognitive impairment, and they may have difficulties in either stopping a behavior or starting a behavior, which can be very important in terms of medication adherence, as Dr. Haddad had mentioned. Next slide, please. So, wanted to highlight again from our substance use disorder collaborative and recognizing substance use disorder in older adults, how it can present differently from younger persons. And you may see indications of falls, you may see cognitive impairment, not taking medications as prescribed, you may see injuries, stress, and sleep disorders. Next slide, please. So some of the challenges is that there are older adults may be likely to be undiagnosed with a substance disorder, and certainly that can be because there are comorbidities that may present similarly. So there may be cognitive impairment, again, because we're talking about the relationship with diabetes and substance use disorder and older adults. There may be comorbidities that are impacting them that may mask recognizing or identifying a substance use disorder. Additionally, we also have screening tools that may or may not be well suited for older adults. And as Dr. Davis had mentioned, the stigma around diagnosing substance use disorder in older adults and the provider bias. Next slide, please. And so just to briefly speak about the issue of stigma and what it can do. And so as Dr. Davis had eloquently had mentioned in terms of the care that they provide to their health center patients at the South End, is to really have this non-judgmental open access approach where harm reduction is employed so that patients understand, and providers as well, that there should not be bias nor stigma. Next slide, please. And then also to just reframe thinking about substance use disorder treatment and thinking about it, reframing it similarly to chronic disease management. So thinking about it in the same frame as hypertensive treatment. Next slide, please. So one of the things that we had talked about in our learning collaborative was the issues around identifying an older adult for substance use disorder. Some of the barriers that can come into play for making that assessment. And you can see here, we not only have patient factors in terms of how they feel about themselves and with regard to their substance use, but also physician factors and some of the bias that they may have around addiction, as well as bias around older adults and how older adults may behave. And then diagnostic factors, comorbid conditions, and how they may obscure or mask other symptoms that would explain substance abuse, as well as some of the age-related changes that we see. Next slide, please. I know this is very difficult, but you'll be able to have this slide as well. And so looking at the DSM-5 criteria for substance use disorder and considering the older adults. And so on the very top, the criteria, a substance is often taken in larger amounts or over a longer period than was intended. And the consideration for the older adults, cognitive impairment can prevent adequate self-monitoring. Substances themselves may more greatly impair cognition among older adults than young adults. And next slide, please. And so we also talked about screening and who should be screened. And in one of our presentations from Ms. Watson, she really had promoted the idea of screening all patients, not just those whom you think may have a problem, because it may be that you uncover abuse for somebody that you never would have thought of. Next slide, please. And so here is some language around introduction to expert training. This is one of the other issues that screening approaches, expert screening approach. And this is particularly informed by a trauma-informed approach. And so asking these particular questions. And so in the middle example, you'll see by drugs we mean medications such as prescription pain pills, prescription sleeping pills, and other prescription medication, marijuana, or illegal drugs. And so thinking about the fact that the substance use disorder may be due to prescribed medications. Next slide, please. And so we closed out our session with talking about this program, the Florida Bright Project, which was a screening and intervention program. And it was specifically focused on screening and brief intervention for older adult substance misusers. So alcohol, medications, illicit substance misuse problems, as well as psychiatric issues. And Dr. Davis had mentioned the connection with substance use disorder and mental health disorders, particularly depression, depressive disorder. And so we wanted to highlight this particular program that really had that focus on older adults. Next slide, please. And these are just some of the lessons learned from Bright that I won't spend any time with, but you can, you'll be able to see in the slide deck. And then next slide. And so the last couple of slides that I wanted to leave you with were some of the case management approaches. And as Dr. Davis had mentioned, taking an integrative approach is very helpful in taking care of individuals and older adult individuals with substance use disorder. And so the case management approach has several advantages. It can speak to a complex multimorbidities in older adults. It can connect them to potentially isolated older adults to their community resources. And it really is rooted in a whole health and has the potential to lessen the stigma of addiction. So I'm going to skip over the last two slides that I have. Again, these are just a couple of programs that you can take a look at. And thank you very much for your attention.
Thank you so much, Dr. Reedy, and it's great to have an NCA partner that really focuses on the elderly. And so please check out the Elderly Cares website for more resources. So we have about 12 minutes left and definitely want to get to some of the questions that have been coming through our Q&A pod. So let me just take a minute to transition as I get those from my team. But just want to give a quick shout out and thanks to, again, all our speakers, Dr. Davis, Dr. El-Haddad, and Dr. Reedy. It has been very insightful and very timely, again, to hear about some of these issues with an increasing elderly population and substance use disorder issue across the US. So let's see if anything has come through. So there's questions for Dr. El-Haddad that we'll have to field offline. But the first one that I think could be answered by Dr. or Dr. Reedy is, what are your thoughts on cognitive decline and the brain being resistant to insulin and diabetes type 3? Any takers, Dr. Davis or Dr. Reedy? Let me double check you're not on mute.
Can you ask the question again?
Sure.
Yeah.
Sure. So the question is, what are your thoughts on cognitive decline and the brain being resistant to insulin and diabetes type 3?
Type 3. So I'm unfamiliar with that concept. I do know that the stress hormone cortisol, which is secreted by the brain, impacts the way sugar is handled and glucose is handled and worsens resistance during stressful periods. That's one connection I know, but I'm not familiar with the type 3 diabetes.
Hi, this is Christine. So I'm not actually very familiar either, but I believe, and maybe the individual that had prompted the question, that it's a term for Alzheimer's disease that may be a result of insulin resistance in the brain. And again, I'm not very familiar, but I've heard the term in a couple of places.
Thank you, Dr. Reedy, Dr. Davis. So if that person is still on, you can help clarify what it is that you meant. But we have another question now is, since both Dr. Davis, all the speakers are actually based in Boston, is there a substance use disorder program for pregnant women in Boston?
Yes. So I know at Boston Medical Center, they have something called Project Respect, which takes care of women with substance use disorders who are pregnant, with special behavioral health clinicians and social workers, and it's led by a family medicine physician who specializes in perinatal care. That's one, and I'm sure there are others, but we interface with them often.
Thank you, Dr. Davis. So remember that Project Respect.
Albert.
I think Dr. Leon has something to say too.
Thank you, Albert. In regards to the first question on diabetes type 3 and Alzheimer's disease, there have been some studies, specifically NIH has conducted some studies on Alzheimer's and diabetes. However, at this moment, based on the information that I have read, these studies are not conclusive. The American Diabetes Association hasn't pronounced or has given any new terms such as diabetes type 3. So this is, there are some ongoing investigations, but this is not something that have been accepted or at least the term hasn't been accepted by any of the organizations studying diabetes. There are some studies, again, NIH has conducted some studies, but there are no conclusions yet.
Thanks for that comment, Dr. Leon. All right, we have another question, and this is for Dr. Davis. Was the non-Hispanic population depicted on the pie chart, I believe it's in reference to slide 31, homogeneous by race or more equally distributed? Parentheses, negating the need to show stratification by race. And I can repeat that again if you need.
No, I think I hear it. It's a very good question. I'd say we definitely have people who are African American. We have one, interestingly, well, no, we have very few Asian individuals, although we have a couple, mostly Southeast Asian. But most, I'd say the majority are white, but we definitely have a African American population. I mean, I'm going to speculate it's about 20% of that, white, of that non-Hispanic portion. But then in the Hispanic portion, some identify as either Black Hispanic or white Hispanic as well. But the data we have that we collected at the time is not so fine-tuned, but I think we will have much more nuanced data for sure. We have a pretty diverse program, but I'd say in terms of the Asian population, it's smaller for sure.
Thanks, Dr. Davis. And we do have one more question, and after that, if we have one more, please type it in. Otherwise, we're going to close out soon. This question is for anybody in the speakers. When looking at team members for the programming you have all spoke about, not only treating substance use disorder, diabetes in general, and in the aging populations, have any of you considered adding physical therapy for those who have physical pain issues to assist with the behavioral health and MAT treatment plans? That's one part. And the second part is, also, have any of you considered adding an occupational therapist to the teams to assist with the activity analysis?
Okay, so I will say that I would love it. We have added just, in terms of other disciplines, we've added an art therapist, and we're hiring we have somebody, actually, we just haven't started yet, an acupuncturist. It's mostly a question of resources and where we prioritize care. We sort of, as I build this program, you have to rank, sort of what you need immediately, and over time you can expand, but you have to get research dollars in order to do it. So it would be invaluable to have both occupational therapy and physical therapy, no doubt. I agree. In fact, some of those supportive services are more important, actually, than what we do as physicians in terms of medication management. So I wish.
Thanks, Dr. Davis. Again, it takes a village, and we can't have everybody without the proper resources. So yeah, great question. So we have 4 minutes left, and I definitely want to give everyone time for announcements. I don't see any more questions, so just let me advance our slides. So we have 2 more upcoming webinars in this Diabetes National Learning Series to keep in mind. Next Thursday is our webinar number 3, Diabetes Continuum of Care, and it's focused on using health promotion behavior change to address childhood and adult obesity and diabetes. And then following week, we have another webinar to close out the series on using the CHW and enabling services workforce to address social determinants of health and diabetes. A mouthful, so please visit diabetes.apsa.org to get the registration links. And you can also find the recordings from the past webinars, including this one. Sorry, this is the next week, but the first webinar is now available on the website, and this webinar today will also be available in the coming days, so please check back soon. So just want to give a big thank you again to our guest speakers, Dr. Davis, Dr. Reedy, Dr. Haddad, and Dr. Leon, and we look forward to seeing you again next week.
Thank you.
And there will be evaluation, so please take a few seconds if you are still on. Otherwise, you'll get it in your email reminder for both the attendees and absentees. Thank you all, and have a good rest of your day.
Thank you.
Thank you.
Thank you.